Morning, friends. Today we are going to have 13th episode of webinar sponsored by East West Pharma. This is their educational initiative for the benefit of postgraduate students all over India. Today, we are having two important topics, both for postgraduate examination as well as your practice in dermatology. The syphilis, even though there is a low incidence some years ago, but it is now appearing in greater numbers. So you have to have a very good idea about what is syphilis, what is the problem, what are the problems, and its real management. And you should update every now and then, because there are a lot of advances are happening in the field of STI. In today's webinar, we have two important persons speaking on two different topics. One is syphilis in pregnancy, and second is congenital syphilis. Both are important. There are a lot of misconceptions regarding the manifestations, the investigation and treatment of syphilis in pregnancy, as well as congenital syphilis. For the examination point of view, congenital syphilis is a stock question in almost all universities. So that's why these two topics are have chosen. And we have two good speakers. One is Dr. Sandhya. She is professor and head of Calicut Medical College, the prestigious institute of Kerala. Second is Dr. Mary Vineetha. She is a professor of dermatology of Calicut, Kottayam Medical College. Now I invite Dr. Sandhya to give her talk on congenital syphilis. Over to you, Sandhya.
Good morning. First of all, I thank dear Crichton sir for giving me this opportunity. And I also thank East West Pharma and Mr. Naveen Kumar for arranging the session. You may be thinking, why learning about congenital syphilis, which is a very rare condition, but this is not the fact. Incidence of syphilis is increasing. So last decade, we have seen a resurgence of syphilis. Actually, there is 7-fold increase in the congenital syphilis between 2012 to 21. WHO estimates that about 7.1 million adults acquired syphilis in 2020. That is in the whole world. Then about US, most of the data is from US. According to CDC, more than 1.7 lakh cases of syphilis were reported in 2021. And of these, more than 50,000 cases were of primary and secondary syphilis, that is infectious stages. Actually, it has reached a historic low in 2000 and 2001. Then the rate is increasing in these past years. Then about the congenital syphilis, the rate in US. Most of the data is from US. Also, our own data also shows that the rate of syphilis is increasing. In 1991, there were about 100 per 100,000 live births. That is 100 cases of congenital syphilis per 100,000 live births. Then it decreased to about 8.2 in 2005. Then there is a mild increase in 2014, that is 11.6. And in 2021, it became 77.9. Very high increase, we can see. So what are the factors which caused increase in the incidence? This data is also coming from US. So it has disproportionately affected patients in non-English speaking household. This shows that the access to the health service is less in this population, in this other population, non-English speaking households. Then of course, low socioeconomic status, low maternal educational level, and high-risk sexual behavior that is increasing now. Earlier with the surge of HIV, there was decreased in 80s and 90s, but now it is again increasing. Then substance abuse, stigma, and an important thing is the decrease in the fund to sexual health services and program. This has also contributed to the increase in syphilis. Syphilis during pregnancy, it will be dealt by Dr. Mary. Just a few words. Syphilis in pregnancy, when not treated, treated late, or treated with incorrect antibiotic, results in 50 to 80% of cases with adverse birth outcomes. It can lead to miscarriage, perinatal death, prematurity, IUJR, or congenital syphilitic baby, or sometimes asymptomatic children also. And according to Kingo and Nicole, it does not cause abortion in 2 to 3 months as Langhans cell layer protects from infection. So with the resurgence of syphilis, we use the term scorch instead of torch because syphilis is also increasing. As for syphilis, cytomegalovirus or others are rubella, T. toxoplasma. So what are the chances of getting congenital syphilis in different stages? So if mother is having primary or secondary syphilis, most likely, it is written most likely the infant will develop congenital syphilis. In some articles, it is written 60 to 100% chance to develop congenital syphilis. That is the early syphilis. In early latent syphilis, there is a chance for 20% for getting a normal baby, and in late latent syphilis, 70% chance for getting a normal baby. These are the chances of getting congenital syphilis in different stages. So about the classification of congenital syphilis, the early congenital syphilis, the manifestation occur in less than 2 years, late manifest after 2 years, and of course stigmata. There is some overlap between these stigmata and other types of syphilis. So before going into the clinical details, we will just have a look at the placenta. Especially in early congenital syphilis, the placenta will be large, thick, and pale. You can see abscess-like foci of necrosis in Wharton's jelly. And in the umbilical cord, there will be necrotizing pneumocystis with spiral stripes of red and blue color. It resembles a barber pole. That is the macroscopic appearance. You can see the picture of barber pole. And histology of placenta, it will show inflammation. So that is the picture of placenta. So that will also give a clue to the congenital syphilis. Then about the clinical features of early congenital syphilis. Early congenital syphilis is mainly due to active infection. In late congenital syphilis, we will see that it is mainly due to inflammation. Here it is due to active infection by Treponema pallida. So antibiotics have a very good role in early congenital syphilis. All of you are familiar with Prophet's law, that is at birth the infant may be normal. He develops signs and symptoms only after a few weeks. So most infants are asymptomatic or having subtle and non-specific symptoms. In 2/3 cases, the clinical signs begin to appear in 3 to 8 weeks. And within 3 months, in nearly all cases of early congenital syphilis will present. An important thing, the earlier the onset, the poorer the prognosis. It ranges from asymptomatic infection to fulminant sepsis to death. And in very severely infected fetus, it may result in hydrops fetalis or result in stillbirth. So an important point, the earlier the onset, the poorer the prognosis. A severe infection will manifest very early. So what are the cutaneous lesions? You can see the skin lesions that develop soon after birth. It will be vesicular and or bullous. Soon after birth, it will be vesicular or bullous. It is called syphilitic pemphigus. The distribution, it will be symmetrical, but more on the palms and sole, up to 3 centimeters. It contains serous or seropurulent discharge, and it will be teeming with treponins, so highly infectious. Infants with this type of rash are gravely ill. And the lesions which develop later, that is after a few weeks. This will be macular or maculopapular, similar to acute secondary syphilis. The it has got a predilection for certain sites like face, around mouth, napkin area, back, palm sensories, etc. Here also you can see condylomata lata lesions can be seen, and palmoplantar lesions will desquamate. So you may see the child or an infant may be in the desquamating stage. So just desquamating palmoplantar lesion, you have to think of congenital syphilis. So you are seeing a neonate with bullous lesion over the hands. You can see also erosions over the elbow, wrist, etc. The neonate will be gravely. You can see also protuberant abdomen. It can affect hair and nail also. It can cause paronychia, especially 4th and 5th digits, atrophic nails, syphilitic onychia. Nail matrix will be involved and there will be shedding of nails. Hair may be brittle and sparse, alopecia of eyebrows, and a peculiar type, that is the syphilitic wig, patchy loss of hair affecting sides and back of scalp. There will be abundant coarse hair which stops short abruptly at hair margin in early congenital syphilis, that is called syphilitic wig. You are seeing the maculopapular rash. You are seeing many lesions over the flexures, condylom, like similar to condyloma lata. You are seeing desquamation of soles. Desquamation of soles, it looks like keratolysis exfoliativa, but in a neonate, you have to think of syphilis, congenital syphilis. Then another important feature is syphilitic rhinitis. It produces a nasal discharge and obstruction and causes noisy breathing, that is called snuffles. Initially, the nasal discharge will be watery, later become thicker, purulent and bloody. It is highly infectious. Because of nasal obstruction, there will be breathing and feeding difficulty resulting in weight loss. Mucus patches can be present, and because of the severe infection, it can involve the cartilage, bone, etc. of the nasal septum, causing ulceration and perforation, causing flattening of nasal bridge, producing the characteristic saddle nose. You know, the saddle is having a concave shape, and there will be flattening of nasal bridge having a concave shape. And throat lesion can occur, causing pharyngitis, laryngitis. This causes the infant to cry in a hoarse voice, and also cough can occur. You are seeing the saddle nose. You can see the concave shape here. Then about the bone lesion, these are also commonly found in early congenital syphilis. Delayed skeletal maturation is seen in almost 30% of infants. And an important thing in the early months of life is osteochondritis or epiphysitis of long bones. X-ray finding, there will be sawtooth metaphysis. Mainly affects the growing ends of long bones. The cardinal signs and symptoms: pain, swelling, and tenderness. The affected limb, because of the severe pain, it is held immobilized. It is called pseudo-paralysis of Barrett. You can see osteitis of fingers, that is dactylitis. An important sign, X-ray finding, is in Wimberger sign. You can see the metaphyseal destruction at the medial part of proximal tibia, that is due to osteochondritis or epiphysitis in early congenital syphilis. Then hematological manifestations, so many manifestations are the anemia, leukocytosis, leukopenia, thrombocytopenia, everything can occur. Then another important finding is hepatosplenomegaly. This occurs in half the cases of early prenatal syphilis. Prenatal is the another terminology for congenital syphilis. And this will result in protuberant abdomen. The transaminase level will be elevated. Jaundice will occur in 30% cases. Actually, jaundice can be due to hyperbilirubinemia, due to hepatitis and hemolysis. There will be associated splenomegaly also. You can see the protuberant abdomen, hepatosplenomegaly is there. Then about CNS involvement. It can be asymptomatic to acute syphilitic leptomeningitis. In a very high percentage of infants with early congenital syphilis, that is 40 to 60% is having abnormal CSF findings. So it can be asymptomatic or symptomatic. Symptomatic, it is due to meningitis or meningoencephalitis. The symptoms are convulsion, bulging fontanelles, stiffness of neck, hydrocephalus, etc. These are the findings. So it in a very high percentage CNS involvement is that is why usually CP or cocaine penicillin is given in congenital syphilis. Then generalized lymphadenopathy can occur as acute syphilis. Then other systems, ocular involvement can occur, choroidoretinitis, glaucoma, uveitis, kidney involvement as nephrotic syndrome, glomerulonephritis. And a specific finding is syphilitic pneumonitis or pneumonia alba because of the fibrosis. It is called pneumonia alba. Then diarrhea due to pancreatitis, myocarditis. These are also manifestations, not very common. So these three features can be considered as a triad of early congenital syphilis, not late congenital syphilis, early congenital syphilis. This can be considered as a triad. That is skin rash on palms and soles, snuffles, and hepatosplenomegaly. If these three are present, invariably you have to rule out congenital syphilis. Then coming to late congenital syphilis. Here, symptoms persist beyond 2 years of age. In many patients, many children, 80% of the children, early stage goes undetected, maybe mild symptoms, and they ultimately diagnosed as having late prenatal syphilis. But now it is rare because of coincidental antibiotic treatment. These correspond to the tertiary syphilis in adult. But cardiovascular system is relatively spared in late congenital syphilis. And here also it can manifest in latent form, that is no symptom, but serology is positive. An important difference from early congenital syphilis, antibiotics have not much help because these are inflammatory reactions. But then also you have to give the correct treatment because some amount of infection is there, so you have to treat the infection. But as these are inflammatory reaction, many consequences many sequelae may persist. So most common late manifestation is interstitial keratitis. So it can manifest from 2 to 30 years or sometimes even later, and females are more commonly affected. They present with photophobia, pain, excess watering, blurred vision. That is why the ophthalmology people, when young people present with interstitial keratitis, they will do VDR. And there can be vascularization of cornea resulting in salmon patch appearance. This interstitial keratitis is self-limited but relapsing. All these will lead to corneal clouding, ground glass cornea. Corneal scarring will remain as a stigmata, and there is a empty or ghost blood vessel that also seen in the cornea. So, you know the triad of late congenital syphilis, Hutchinsons triad consisting of interstitial keratitis, eighth nerve deafness, and Hutchinsons teeth. Of these, interstitial keratitis is the most common. So you are seeing the corneal scarring. Coming to eighth nerve deafness, this is the least common of Hutchinsons triad. Here, the pathology, the primary lesion is the osteochondritis affecting the otic capsule. It leads to cochlear degeneration, usually occurs around 10 years. The first symptom to appear is tinnitus, and after some time vertigo will occur, and after some time there will be loss of hair. That is progressive. Prognosis is poor in untreated cases, and even with adequate antibiotic therapy, deafness is progressive. All these are inflammatory things. Then about Hutchinsons teeth. This is a triad of Hutchinsons triad. This is one feature of Hutchinsons triad, and also it is a stigmata. It is one of the most commonly observed stigmata affecting the permanent incisor teeth, described by Jonathan Hutchinson. Tooth buds of permanent incisor develop in the later part of pregnancy. So infection interfere with nutrition of tooth buds and it causes suppression of middle denticle. And lateral denticle expand to fill the gap. This will produce the notch-like appearance. And coming to late congenital syphilis. Early congenital syphilis, it can be asymptomatic or presents as meningitis or encephalitis. Here it is like acquired neurosyphilis. Can be asymptomatic, can be meningeal, vascular or parenchymatous. So parenchymatous, it can be juvenile GPI or juvenile tabes. Juvenile GPI, general paralysis of insight, the child presents with dementia. He becomes careless, dirty, incapable of concentrating. There will be gross change in character and sometimes convulsions can occur. Juvenile tabes is milder when compared to adult. Then bones. You have already studied early congenital syphilis. There will be osteochondritis or epiphysitis. Here it is mainly osteoperiosteitis, occur between 5 to 20 years. Here there will be sclerosis and newborn formation, and tibia is the most commonly involved. Because of the sclerosis, there will be thickening of the middle third of the bone. But although there is thickening, the portion will be weak and hence it will be bent and bent like a sword. Hence the appearance is called saber tibia or saber blade tibia, meaning sword-like. Then you can get destructive lesions over the palatal bone, nasal septum, etc. Another feature is the localized periosteitis of bones of skull. There will be rounded bony swelling called parrot's node, which can occur in early congenital syphilis also, but usually in late congenital syphilis. Most common in the frontal and parietal areas. Because of the thickening, it gives the impression of thinning of rest of bones. Actually, there is no thinning, but gives the impression. Hence, the name craniotabes. Means softening of, actually that means softening of bones, but actually there is no softening, but gives the impression of thinning. Hence, name craniotabes. You can see the sword-like saber tibia. It can be observed in other conditions as well. Not only syphilis, other conditions affecting the bone can also present with saber tibia. Then gummatous destruction of a nasal septum. The cartilaginous part will collapse and there will be gross depression of the lower part of the nose. Hence, there will be a well-marked ridge between cartilage and bone. And hence, the anterior nails may be tilted forward. Actually, it is different from saddle nose, which result from failure of proper development of bones of nasal cavity due to syphilitic snuffle early in life. That is, in early congenital syphilis, classically produces saddle nose deformity. Here it is slightly different. So saddle nose deformity is this. You can see the concave nasal bridge. Here there is collapse and there is a bridge, there is a ridge between cartilaginous and bony part and anterior nair is tilted upwards. This looks like gummatous destruction. Actually, this photo, it is not of syphilis. It is some granulomatous polyangiitis affecting the nasal bridge. But the picture is similar to gummatous involvement. Another feature is Higominaki sign, that is thickening of the inner end of clavicle, that is Higominaki sign. Another important thing is the Clutton's joint, first described by Clutton, occur between 10 to 20 years. It will be painless, insidious and chronic, mainly affecting both knee joints. Consists of simple effusion without evident inflammatory changes in joints or periarticular tissue. There is little impairment of function. X-ray show enlargement of joint space but no bony changes. Here also antisyphilitic treatment has no role. So it is a painless, it doesn't impair the function of the joint. Then coming to the stigmata of early syphilis. Facies. There is a characteristic facies. The most importantly, the facial disfigurement, it is due to severe and persistent rhinitis in the infancy. Another facies described is Stokes facies. The person will be having inalert face. a sad look can be seen. Then another thing is the infection. It will interfere with the growth and development of the nasal septum and other bones of nasal cavity. So saddle nose deformity. Then maxilla, it will fail to develop normally, resulting in high arched palate. And because of the failure of the maxilla to develop, the mandible looks prominent and overdeveloped by comparison. This is called bulldog jaw. Saddle nose, you can see the bulldog jaw. Prominent mandible is there. Maxilla is underdeveloped. Moon's molar or mulberry molar, mainly affecting the lower molar. The tusks are underdeveloped, hence looks numerous. But these are poorly enameled and very prone to caries, and soon they are lost. Another thing is bragades, usually occur around the mouth due to papillary eruption in early syphilis, and movement of mouth pore causes radiating fissures and which becomes secondary infected and results in scarring. Then many other stigmata are the pepper and salt fundus, that is due to choroiditis, ghost vessels in cornea due to interstitial keratitis, perforation of nasal palate, nasal septum and palate, saber shin, then hot cross bun skull, that is frontoparietal boson due to healed gummatous osteoperiostasis, bulldog facies, optic atrophy, nerve deafness, all these can persist. Then the boy sign, that is shortened fifth finger. Actually, so many other features are there, but because of time constraint, I am not telling everything. So how will you evaluate and treat the neonate? Actually, the diagnosis of congenital syphilis is difficult because maternal IgG is transferred through placenta to fetus. Hence, treatment decision is based on 4 factors. 1. Identification of syphilis in mother. 2. Adequacy of maternal treatment. 3. Presence of clinical, laboratory or radiographic evidence of syphilis in neonate. 4th, comparison of maternal at delivery and neonatal non-treponemal serological titer, RPR or VDR. It is non-treponemal serological titer by using the same test, preferably conducted by the same lab. So, the treatment decision is based on these 4 factors. So, general guidelines are these. All neonates born to mothers who have reactive non-treponemal and treponemal test result should be evaluated with RPR or VDR performed on the neonate serum, not umbilical cord blood. It should be the same type of non-treponemal test performed on the mother. Conducting a treponemal test like TPHA on neonatal serum is not recommended because it is difficult to interpret, as passively transferred maternal antibodies can persist for more than 15 months. And also, commercially available IgM tests are not recommended. Next thing, examine the baby thoroughly for congenital syphilis. Then you can do the pathological examination of the placenta or umbilical cord using specific staining like silver staining. Then dark field or PCR testing is, if available, of suspicious lesions or body fluids like bullous rash or nasal discharge can be performed. For stillborn infants, skeletal survey can be done because bone defects are not detected in fetal ultrasound. So these are the general guidelines. So CDC has described 4 scenarios in the management of congenital syphilis. So I will tell all the scenario. First scenario, that is the confirmed, proven or highly probable congenital syphilis. So here the mother, the non-treponemal test is positive with any neonate with abnormal physical examination that is consistent with congenital syphilis, abnormal physical examination, or a serum quantitative VDRL or RPR that is 4-fold higher than mother's titer at delivery, or a positive dark field test or PCR of placenta, cord, lesions or body fluids, or a positive silver stain of placenta or cord. If any of these is present with VDRL positivity in the mother, but how will you evaluate? You have to do the CSF analysis for VDRL, cell count and protein, CBC, long bond radiographs, and other tests as clinically indicated. You have to do all these evaluation. So how will you treat this confirmed or highly probable syphilis? You have to give aqueous crystalline penicillin. CP you have to give 50,000 units per kilogram body weight IV. First 7 days, it is 12 hours, every 12 hours. That is BD dose in the first 7 days and TID dose, that is every 8 hours for a total of 10 days. First 7 days BD dose, then 3 days TID dose. 50,000 units per kilogram body weight, that is crystalline penicillin. Or you can give procaine penicillin also, procaine penicillin G. Here also the dose is say 50,000 units per kilogram, but single daily dose is enough. IM, it is IM, other thing was IV, that is also for 10 days. So CP or procaine penicillin is given, and if more than 1 day of therapy is missed, the entire course should be restarted. That is very important. So first scenario, highly probable congenital syphilis. Second is possible congenital syphilis. Here also mother is VDR positive plus neonate who has normal physical examination and a serum quantitative non-treponemal serological titer equal to or less than 4-fold of the maternal titer at delivery. For example, maternal titer is 1 in 8, neonatal titer less or equal to 1 in 16. And one of the following. Normal, physical and equal serological titer equal to or less than 4-fold plus one of the following. Mother was not treated, was inadequately treated or has no documentation of treatment. Or the mother was treated with erythromycin or a regimen other than those recommended in this guideline. Or mother received the recommended regimen, but treatment was initiated less than 30 days before delivery. So if any one of these three is there, you do the evaluation, CSF analysis you have to do, CBC and long bone radiographs. This is the scenario of possible congenital syphilis. How will you manage? Here also you have to give CP or procaine penicillin same dose, but here there is a third choice. That is, you can give benzatine penicillin also. Here also the dose is 50,000 units per kilogram body weight, single IM dose. But before using the single dose benzatine penicillin G regimen, the recommended evaluation, that is CSF examination, long bone radiograph, CBC, platelet should be normal and follow-up should be certain. Only in this situation, you can give benzatine penicillin. And if any part of the neonates evaluation is abnormal or not performed, if CSF analysis is uninterpretable because of the contamination with blood, or if follow-up is uncertain, a 10-day course of penicillin G is required. So there are 3 options. You hope you understood. And here, when the neonates test is negative, we are not sure whether the mother is treated, and neonates test came negative. If the provider determines that the mother's risk for untreated syphilis is low, treatment of the neonate with a single IM dose of benzatine penicillin for possible incubating syphilis can be considered without an evaluation. That is one thing which can be done if the neonate test is negative. But in a neonate born to mothers with untreated early syphilis at the time of delivery are at increased risk for congenital syphilis, and the 10-day course of penicillin G should be considered even if the neonate's non-treponemal test is non-reactive, the complete evaluation is normal, and follow-up is certain. That is, if that neonate's test is negative, but mother had untreated early syphilis at the time of delivery, then there is a very high risk for congenital syphilis. Even if the neonate's test is negative, you have to give the penicillin G itself. Then scenario 3, congenital syphilis is less likely. Here, neonate with normal physical examination, serum quantitative non-treponemal serological titer equal or less than 4-fold of maternal titer at delivery, and both of the following are true. That is, mother was treated during pregnancy. Treatment was appropriate and the treatment regimen was initiated more than 30 days before delivery. And mother has no evidence of reinfection or relapse. This scenario we can encounter many times in our hospital also. Here, no evaluation is recommended. But here also, the CDC is advising benzalkonium penicillin. Although the mother is treated and the child is having a low titer positivity, then also CDC is advising benzalkonium penicillin because whenever there is even a small degree of doubt, you have to give treatment for congenital syphilis. But another approach is also there. No treatment of newborn if follow-up is certain, but providing close serological follow-up every 2 to 3 months or 6 months has to be done. Then the last scenario, scenario 4, congenital syphilis is unlikely. Any neonate who has a normal physical examination and serum quantitative non-treponemal serological titer equal to or less than 4-fold of maternal titer and following are true. Here, same, almost same like scenario 3. Mother's treatment was adequate. And another thing, mother's non-treponemal serological titer remained low and stable before and during pregnancy and at delivery. That is a low titer positivity during pregnancy, and the patient was also treated also less than 1 in 2, 1 in 4, etc. Not that the patient was having early syphilis and treated, the patient having a low and stable titer. Here, no evaluation is recommended. No treatment is required. However, any neonate with reactive non-treponemal test should be followed serologically. If VDRL is reactive, the neonate has to be followed up until it becomes negative. If follow-up is uncertain, you may consider giving benzalkonium penicillin G. For an infant or a neonate, the reaction to penicillin is very less. And if there is congenital syphilis, there is a high risk of developing any problem. That is why whenever there is doubt, you give treatment. And for the treatment of late congenital syphilis, CDC recommends that any child with late congenital syphilis treated with crystalline penicillin 50,000 units every 4 to 6 hours for 10 days, plus a single dose of benzalkonium penicillin G 50,000 units. IM may also be given at the completion of IV therapy. There are many case reports now coming. I just described 2 case reports. Many antenatal cases are not screened. So there will be missing of patients. The neonate was normal at birth, but at 2 months of age, the infant presented with failure to thrive, snuffles, maculopapular rash, and bulging fontanelle. Important thing was that initial PDRL test was falsely negative due to proson phenomenon. Later turned out to be 1 in 256 reactive. So even if PDRL is negative, if there is high degree of doubt, you have to repeat PDRL. Then another child, 2-week-old male infant, presenting with diffuse erythematous desquamation and fissures on hands and feet. Then linear fissures on angles of mouth, hepatosplenomegaly, snuffles, etc. So VDRL was again 1 in 256. So this manifestation is very important. You may not see the bullous lesion, just erosion or peeling of skin in the extremities. You have to do the VDRL. So many case reports are there, but actually this is a vast topic, but because of the time constraint, I am winding up the talk. Thank you for listening.
Thank you. Oh.
Good afternoon, all. First of all, let me thank Titan sir and East West Pharma for giving us an opportunity to present this topic here, and also Mr. Naveen Kumar for all the technical assistance. So today we will be discussing about the topic syphilis in pregnancy. What's the importance of this topic? So here we are treating 2 individuals, mother and the fetus, as well as the partner of the mother. We should make sure that all these individuals are cured of the disease and we are not using any drugs which could be detrimental to the health of the baby. So let's start with this drama, Les Everest. I hope everybody will be interested in hearing a story of this drama. This is actually a French drama, Les Everest. Its meaning is damaged goods. This drama was playing in the theaters of France in year 1901, and it was written by a French playwright, Eugene Bruce. This drama depicts the story of a male who is infected with syphilis and is going to get married soon. So his doctor advises him to wait for a few more years until he is cured of the disease, as he was having early syphilis and it was infectious to his partner. But at that time, treatment for syphilis was with mercury, and it will take around 3 to 4 years for complete treatment. So this male was not agreeing for postponing the marriage, and he marries the girl soon, and she gave birth to a baby with congenital syphilis. This baby was very sick. He also appointed a vet nurse for the baby. So at that point, this doctor was forced to disclose the diagnosis to the vet nurse. She leaves the home, and the other members in the family also come to know about the disease of this person. So finally, what happens is the girl's father pleads for a divorce in the court, and also this father of the girl, asks court that there should be some law implementing examination for sexually transmitted infection mandatory before marriage. And this drama concludes with the advice by the doctor that there is no need for any law, but there should be education in the community regarding this sexually transmitted infection. We should be able to come out of the stigma related to this STI, and we should be able to discuss these STIs in public. This drama was banned in some areas of France because it was a time when there was profound stigma regarding sexually transmitted infections, and the people were not willing to discuss about these sexually transmitted infections in public. And we know this drama is still relevant in 2024. Why? As per WHO reports, as Sandhya madam already mentioned, syphilis cases are increasing. Around 7.1 million adults between 15 to 49 years acquired syphilis in year 2020. And the syphilis in pregnancy, parallel, the incidence of syphilis in the community, especially in the reproductive age group. And improper management can lead to 50 to 80% adverse pregnancy outcome. Definitely, the cases of congenital syphilis is increasing, and it's a reflection of the quality of antenatal services and the STI control programs. And this is the statistics from Kottayam. And here we can see that after a steady dip during the COVID year, we have a steady increase in the cases of syphilis. And this is the statistics from Calicut Medical College. Here also we can see the cases of syphilis is increasing. And they say the cases of latent syphilis is increasing, or the late syphilis is increasing, but definitely the early syphilis cases are also increasing, as we can see from the chart. So this is the statistics of pregnancy, syphilis in pregnancy from our institution in the last 6 years. We had a total of 20 cases in last 6 years, and most of these cases were in the second trimester. And majority of these cases were late latent syphilis and syphilis of unknown duration, and most of them were treated with benzathine penicillin, but 2 patients were treated with crystalline penicillin as they had neurosyphilis, and 2 cases with erythromycin base. So now we will see the clinical features of syphilis in pregnant women. It's not very different from the syphilis in other normal persons. That is, these pregnant ladies may be in the early syphilis, in which they acquire the infection within the first year, in the previous year, or it may be late syphilis, where they acquired infection more than 1 year. And also they may be in the primary stage or in the secondary stage, early latent stage, late latent stage, neurosyphilis or cardiovascular syphilis. So these ladies may be in any stage of syphilis. And some studies says the primary chancre may be smaller in size in these pregnant ladies, and also cervical chancre may be more common. And in unsupervised mother, always the lesions of early syphilis go unnoticed. WHO says 7 in every 1,000 pregnant women had syphilis, but it's an older statistics in year 2016. And 6.5% of babies with congenital syphilis were stillborn or they died in 30 days. So what's the outcome of undetected syphilis in pregnancy? Previously, it was thought that the spirochetes will not infect placenta until 20 weeks of pregnancy. as a Langerhans layer in the placenta gives protection against infection. But now in the recent studies, it was found that even in the early abortus of 9 to 10 weeks, spirochetes were demonstrated. So the spirochetes can cause infection in baby at any age of gestation, even from the most early ages. So the pregnancy outcome included could be abortion, intrauterine growth retardation, preterm delivery, or even the congenital syphilis. We all are aware about the Kasowitz law, which states that a lady infected with syphilis will have an abortion in the second trimester, then she may give rise to a stillborn baby later, then finally a baby with congenital syphilis who will die soon, then a baby with congenital syphilis who will live, and finally she may have a healthy baby. So why this difference? That is, as time passes, this mother becomes less infectious to the baby. So it said that the probability of transmission to the baby, that is the chance for the baby to get infection, is 100% if the mother has early syphilis, but after 4 years it becomes around 70%. And also the chance of congenital syphilis in the baby is 50% if the mother has primary and secondary syphilis. It is around 40% if the mother has early latent syphilis, and 10% if the mother has late latent and tertiary syphilis. That's the possibility of congenital syphilis. The other one is the chance of baby getting infected. And the neurosyphilis in baby is likely if the mother is in the secondary syphilis stage or mother is having early latent syphilis. So what are factors determine the outcome of pregnancy in syphilis? Always the treatment improves the pregnancy outcome, and the untreated gravid has 12 times more chance of pregnancy-related complications. I already mentioned the pregnancy outcome depends on the stage of syphilis of the mother. That is, if the mother is in the early stages of the syphilis, there is higher chance that the baby get infected or the baby has congenital syphilis. And another factor which determines the pregnancy outcome is the gestational age of treatment, that is time at which we treat the mother. If we give treatment to the mother earlier, the chances of getting infection in the baby is less. So it said that if we treat the mother in the first trimester, the chance of congenital syphilis in baby is only 10%. If it's in the second trimester, it rises up to 18%, and in third trimester, the chances of congenital syphilis in the baby, if the mother having early syphilis, is 41%. So earlier the treatment, better the outcome. So coming to the pathology, the pathology or the changes in the placenta. So this placenta will get infected at any stage of gestation, but usually the abortion usually occurs in the second trimester. This is because the baby can mount an immune response against this infection only after 20 weeks. This placenta will show many changes like acute and chronic inflammation, necrosis. Pneumocystis, that is the inflammation of placenta, is the histological marker of fetal response. There could be necrotizing pneumocystis, and in advanced cases, endarteritis, decrease in blood vessels, etc. And in 42% of affected cases, pneumocystis was demonstrated. So this study on the pregnancy outcome in syphilis, they found that total adverse pregnancy outcome was 76%. Congenital syphilis occurred in 36%, preterm birth and low birth weight in 23% each, miscarriage in 14%, stillbirth in 26%, and neonatal death in 16%. So now we know the clinical features and the pregnancy outcome in a mother, in the fetus of a baby, fetus of a mother infected with syphilis. Now we will see how to screen the mothers. So in India, one advantage is that our antenatal coverage is very good. So we can screen the mother in the first prenatal visit itself. And in high-risk areas, they say we should repeat screening at 28 weeks of pregnancy and just prior to delivery, that is late in the last trimester. So we know in our area, the syphilis cases are increasing, so definitely we should repeat investigation. Even though the first screening test is negative, we should repeat investigation or repeat the screening test at 28 weeks and late in the last trimester, not to miss any cases. And if screening is not done during pregnancy, it should be done during delivery or soon after delivery. And the usual screening test which we do is RPR, rapid plasma reagent test, or the VDRL test. But we should know that this RPR could be biologically false positive in 28% of cases. So if it's positive, we should confirm it using a specific test, that is TPHA. And HIV screening should be done in all these cases because there is already an inflammation in the placenta. And so if the mother is infected with HIV, there is high chance that it's transmitted to the baby. So this is a screening algorithm for syphilis. This can be done in all cases. And here we are following the traditional algorithm. But we have the reverse screening algorithm also. But in our institution, we are following traditional algorithm where we will do RPR or VDRF first. That is a non-specific test which is most sensitive. That is the RPR test that we will do first. If it is non-reactive, there is no evidence of syphilis. But it's reactive. If it is reactive, we should rule out if it is biological false positive. So we will do a specific test, that is TPHA or TPPA. TPPA is Trypanosoma pallidum particle agglutination assay or FTABS. In our institute, we are using TPHA as a specific test. If it's reactive, that means the patient is having syphilis. We should evaluate for the syphilis and treat accordingly. But if TPH is non-reactive, that is only the RPR is positive and TPH is non-reactive, that means it could be a biological false positive reaction and syphilis infection is unlikely. Then why we are doing this reverse screening algorithm? We know this RPR is a highly sensitive test, but in the late syphilis or in the late latent syphilis, its sensitivity is less. So we may miss few cases of late latent syphilis. So that's why a reverse screening algorithm was also proposed. So in reverse screening algorithm, we will do a specific test first, that is the enzyme immunoassay first. If it's not reactive, then okay, there is no syphilis, but it's reactive. We should do a non-specific test, RPR. If RPR is also reactive, we should evaluate the mother and treat for syphilis. If RPR is non-reactive, then do another specific test, that is TPPA or TPH. If that is non-reactive, the initial EIA positivity could be a false positivity. If TPHA is also reactive, that is two specific tests are positive, that is EIA and TPHA, then the mother should be evaluated and treated for syphilis. That is a reverse screening algorithm, but we are following this traditional algorithm. So in most of the cases, we will find that as in our study, it was found that most of these mothers will be detected to be serologically positive, but few cases may be having signs and symptoms of syphilis also. So if the mother has clinical lesions of syphilis, or if they have serological positivity, we should take an appropriate sexual history. We should take history for any illicit drug use. And antenatal frequency of antenatal checkups should be assessed, and also the social aspects of the patient. We have come across many perplexing scenarios while dealing with cases of pregnancy syphilis. In our area, the migrant population is increasing, and most of them are not aware of the facilities of antenatal checkup. So in such cases, mothers will be detected to be VDRL positive few days prior to EDC or sometimes even after delivery. So there is high chance that the baby is getting infected with congenital syphilis. Another issue is history of penicillin allergy in these pregnant ladies. And another interesting case was a case of pseudocyesis. Actually, that lady was second trimester pregnant lady, and she was referred from gynecology department for benzathine, but after admitting, we found that it was a case of pseudocyesis. She was not pregnant. Another problem is that we have many live-in relationships in our community now, and some of these ladies may get pregnant and they may be infected with syphilis, and we will have to give benzathine penicillin, and at the time of getting an informed consent, a legally authorized representative may be lacking. So that is another issue for us. Another problem is missing doses, especially that is in the case of latent syphilis. When they need to take 3 doses of benzathine penicillin, they may miss a dose in between. So that is another problem in pregnancy. So apart from this, other investigations which we should do in cases of syphilis in pregnancy is the ultrasound abdomen. That is in the second trimester, we should do an ultrasound abdomen to assess the features, to see for any features of congenital syphilis in the baby. And if the mother is in the late latent syphilis phase or in the phase of syphilis of unknown duration, we should get a neurology, cardiology, and ophthalmology evaluation to see for any involvement as the treatment is different. The ultrasound evidence of congenital syphilis is evident only after 20 weeks. That's why I said it should be done in the second trimester. And the most common feature is hepatomegaly. Other features include fetal anemia, placentomegaly, polyhydramnios, ascites, fetal hydrops, splenomegaly, and cardiomegaly. And after treatment, this placentomegaly and hepatomegaly persist longer, but the other features may disappear. And there is more chance for garish eczema reaction if there are ultrasound changes. And serial ultrasound should be done in affected babies. So this is just a chart to show how to evaluate a mother with syphilis. So now we know the clinical features of syphilis. We know the screening test and the investigations which we should do in case of syphilis. Now we will move on to the treatment guidelines. And we are following the STA treatment guidelines proposed by CDC in year 2021, or we can follow the NACO guideline, which is also similar. And CDC says benzathine penicillin is the only effective drug in treating syphilis in pregnancy. So here we should make sure that the mother is cured of the disease. And the drug which you are giving to the mother should cross the placenta and it should cure the baby. So these are the factors which we should take into account while treating a case of syphilis in pregnancy. And the studies say benzathine penicillin is 98.7% effective in preventing maternal infection as well as treating the baby. And any other alternative treatment is associated with high rate of congenital syphilis. Now, we cannot give doxycycline because doxycycline is the alternative regimen which we give for non-pregnant ladies who are allergic to penicillin or who are not willing to take penicillin. But doxycycline is a pregnancy category D drug. It can cause permanent abnormalities in the teeth formation and also many other congenital birth defects. So it cannot be given during pregnancy. And many other drugs are under trial for treating syphilis in pregnancy in cases who are allergic to penicillin, but none of them is proven to be efficacious. And the most rated among these different drugs is Syphiilis. And the Syphiilis was found to cross the placental barrier, but it's still under phase 2 trial. So in early syphilis, if the mother is having early syphilis, we can treat with injection benzathine penicillin 2.4 million unit IM, and we give it as 1.2 million unit on each buttocks, deep IM after test dose, and after taking an informed written consent from the patient and the bystander. In case of latent syphilis and latent syphilis of unknown duration, we should give 3 doses at weekly interval. And we should make sure that the partner is treated. Otherwise, this mother will get reinfected, and counseling should also be provided. So what are precautions we should take before giving benzathine penicillin? So first, you should ask for the history of penicillin allergy. Then you should get an informed written consent. And this consent should include the complications, risk of anaphylaxis to the mother, as well as the risk to the baby. And it should be signed by the patient as well as by the bystander. And we are giving at least 2 or 3 benzathine penicillin per month in our institution. And we are giving this benzathine in an ICU setup where anesthetist is available to manage the anaphylaxis if any untoward happenings occur. And we should put a wide bore IV cannula before giving the. So first we should take informed consent. Then when we will ship the patient to ICU, we will put a wide bore cannula. We will start normal saline drip. We will make the crash cart ready to deal any emergencies. And then we will give the test dose. So we will wait for 30 minutes. We should wait for 30 minutes after giving the test dose and see for any erythema, infiltration, or pseudopod-like appearances using a torch and lens. You should use a torch and lens to see for any changes at the test site. And after 30 minutes, if there is no reaction at the test site, we can give the injection. And we should monitor the patient for further 30 minutes for any reactions. If any anaphylaxis is to occur, it will occur immediately. And we will admit the patient for 1 more day to observe for any evidence of garish eczema reaction in the mother and also the baby. Fetus should be monitored if there is any garish eczema reaction. And in pregnancy, if we are treating a latent syphilis, not more than 9 days of gap should be there between 2 doses. Sometimes some mother will not come for the next injection in the proposed date. So if there is more than 9 days gap in between 2 doses, we should again restart the injection. And some experts says in early syphilis, we know the chance of infection in the baby is high, as his spirochetemia is more. And also there are many physiological changes in pregnancy which decrease the bioavailability of drug. So the chance of treatment failure and the chance of infection in the baby is high in early syphilis. So some experts say we can give 2 doses of benzathine penicillin in early syphilis, but that is not taken up by CDC. We are still giving single doses. So come to the complications of therapy with penicillin. We all know the most dreaded complication is the anaphylaxis. Then the next complication is Jarisch eczema reaction. The chance of Jarisch eczema reaction is 40% in pregnancy. It usually occurs 2 to 8 hours of injection. Anaphylaxis occurs immediately and Jarisch eczema reaction occurs 2 to 8 hours after injection. And it can lead to some fetal complications also. There will be preterm contraction, fetal heart rate changes, decreased fetal movement, preterm labor, and even stillbirth. So when you are taking an informed consent, you should tell the patient and bystanders about the possibilities of Jarisch eczema reaction, which can cause fetal complications too. So now you know how to treat the patient. Now how to monitor the treatment. We expect a 4-fold decrease in titer, RPR titer after treatment. And in early syphilis, this is possible after 6 to 12 months. And in late syphilis or syphilis of unknown duration, it may take even up to 24 months. And in HIV positivity also, it may take 24 months. And in different studies, it was found that at delivery, only 38% achieved this fall in titer. And this fall in titer, we all know it depends upon the time of treatment, that is gap between the treatment and testing, and also the stage of disease of the mother. And always some low titer, if the mother is having low titer, it may not fall so easily. And some experts say in pregnancy, we should repeat testing every 4 weeks so that we can detect the reinfections and treatment failure earlier, but CDC does not recommend it. And the chance of treatment failure is high if the maternal titer of RPR is more than 1:32, and also if the mother took treatment within 28 days of EDC. So there are certain controversies regarding treatment of syphilis in pregnancy. The one I already mentioned, the recommendation for additional therapy in early syphilis, but CDC does not take up this recommendation. And some studies also showed extra dose is not beneficial. And other controversy is on the alternate drugs. If the mother is allergic to penicillin, CDC says no other drug is effective in treating syphilis in pregnancy other than penicillin. But there are many drugs in trial. Some drugs like amoxicillin, erythromycin, ceftriaxone, cefixime were tried in different studies. And there is another controversy regarding erythromycin also. Erythromycin is not effective in treating syphilis in pregnancy. Erythromycin is available as base, estelate, and stearate. Erythromycin estelate is said to cause hepatotoxicity. But recent study says it does not cause much hepatotoxicity compared to other erythromycin base or erythromycin stearate. Erythromycin estelate and stearate are not available now, and only the erythromycin base is available, and that is also not proven to be efficacious. So this penicillin allergy is the most difficult situation in managing a pregnant syphilis because there is no proven alternative to penicillin. But we should know that there is some over-reporting of penicillin allergy. Some patients will be having some gastritis after taking penicillin and they say it's penicillin allergy. So we should take a proper history before labeling a patient as penicillin allergy. And this risk assessment should be done whether it is a low-risk penicillin allergy or a high-risk penicillin allergy. Even though the prevalence of penicillin allergy is said to be 8.3%, the objective penicillin allergy is seen only in 2.5%. And 80% of cases with true IgE-mediated reaction lost, they will come out of this sensitivity after around 10 years. And if a patient is allergic to penicillin, cross-sensitivity to third-generation cephalosporins like ceftriaxone is only less than 1%. So it's safe to give ceftriaxone in patients without history of IgE-mediated symptoms, not in pregnancy. And the cross-sensitivity of penicillin with first and second generation cephalosporins is around 1 to 8%. It is a bit higher. So what do you mean by low-risk penicillin allergy? That is, the patient gives history of a pruritus without rash, localized rash, delayed onset rash, and unknown symptoms. That's a low-risk penicillin allergy. And high-risk penicillin allergy, definitely, that is the immediate hypersensitivity reaction, like urticaria, angioedema, anaphylaxis, hoarseness of voice, bronchospasm, hypotension, and that history is within the last 10 years. That's a high-risk penicillin allergy. So if a pregnant lady gives history of penicillin allergy, we need to find out whether it is a true penicillin allergy. So we can do skin test using the major and minor determinant, followed by an oral challenge with 250 milligram amoxicillin. The major determinant is benzyl penicillin polyl lysine, and the minor determinant is benzyl penicilloate. And 90 to 99% of true cases of penicillin allergy can be identified by this test. That is skin test followed by oral challenge test. And if the skin test and the oral challenge test is negative, the risk for anaphylaxis is 0. The skin test could be either pinprick test or intradermal test. But we should know that we should not do this penicillin testing in patients who has history of Stevens-Johnson syndrome or toxic epidermal necrolysis. So after doing penicillin testing, if the patient is found to have true sensitivity or truly allergic to penicillin, CDC recommends penicillin desensitization. But in our institution, we are not doing penicillin desensitization for pregnant ladies with syphilis, as there is risk to the mother as well as the baby. So alternative treatment which we give is injection ceftriaxone 1 gram IV once daily for 14 days in early syphilis and for 28 days in late syphilis. But this is not as per CDC recommendation. As we are not doing penicillin desensitization, we are giving this regimen. And there was a study which was published in International Journal of STD and AIDS, which says that ceftriaxone can be an alternative treatment method in pregnant women with syphilis, but it's not recommended by CDC or NAP. So CDC says you should do oral desensitization in patients who are pregnant ladies who are allergic to penicillin. And this oral desensitization to penicillin is done with penicillin V. And we will give increasing doses of penicillin V at an interval of 15 minutes. And the total time taken for this oral desensitization with penicillin V is around 3 hours and 45 minutes. And once the desensitization protocol is over, 30 minutes later, we can give the full dose of benzathine penicillin G injection IR. So now we know the clinical features, screening, investigations, management, and managing the problems associated with syphilis in pregnancy. Then why these cases of congenital syphilis is increasing? So there is some lacuna somewhere. So what's that? One problem is delayed receipt of result. So after investigation, they will be giving the result the next day. So some patients may not come for follow-up. Then failure to adhere to recommendations, late diagnosis, and improper monitoring of cure. These are some problems. So how community level prevention is possible? That is by increasing the accessibility to antenatal services, early screening and adequate treatment, identification and treatment of partner, and modification of high-risk behavior. So at least one screening test should be done in early pregnancy, and if not done, it should be done at delivery or soon after delivery. Decentralization of syphilis screening programs in pregnancy may be a bit more useful, as on-site testing or rapid syphilis test could be done in resource-poor settings, especially in primary health centers, where even an untrained personnel can do this rapid syphilis test, and we can treat the patients accordingly. As per WHO statistics, each year maternal syphilis leads to 4.6 lakh abortions or stillborns, and 2.7 lakh congenital syphilis and premature or low birth weight babies, and adverse results in pregnancies 12 times higher in women who are not treated. So WHO put forth a triple elimination initiative of mother-to-child transmission of HIV, syphilis, and hepatitis B. And as per this triple elimination services, this testing for HIV, syphilis, and hepatitis B is offered for the pregnant ladies, prompt treatment of ladies who are infected, counseling for the woman and partner, and appropriately attended and safe delivery is promoted. Appropriate follow-up, optimal infant feeding, and lifelong treatment and care for mothers is provided. And these are the indicators for elimination of maternal to fetal transmission of syphilis proposed by WHO. That is the congenital syphilis case rate of less than 50 per 1 lakh live birth, and more than 95% antenatal coverage, coverage of syphilis testing, and adequate treatment of syphilis. So what is our Indian scenario? Our antenatal coverage is 89.6%. Screening of the pregnant ladies for syphilis is 65%. And out of this, ladies who were tested to be positive, 35.8% was treated. And the average seroprevalence of syphilis in pregnant ladies is 0.38%. So here we know only 35.8% of cases who were detected to be syphilis, detected to have syphilis were treated. Only 35.8% was treated. But this is a older statistics in year 2015. So why this disparity? So what are the challenges which we face in our country? So one is lack of trained staff and guideline for screening pregnant women at root level. Limited information, education, and communication. People as well as the official are not aware of this increasing trend of syphilis infection and the detrimental effects of syphilis in pregnant women and the baby. Another cause is late antenatal attendance. And there are many parallel service delivery programs in India which reduce the chance of screening in the mother. Then another is fear and reluctance to use benzathine penicillin, lack of monitoring, as well as the stigma and discrimination which is still prevalent in our community. So how to act? There should be a strong political will so that funds can be released for the screening services as well as for the treatment of the baby and for IEC activities. There should be standardization of medical care and improve the dissemination of the knowledge regarding evidence-based knowledge regarding the management and screening of syphilis, and also development of clinically useful diagnostic test. And we should change the public perceptions of syphilis. We should come out of the stigma associated with syphilis. So we have to go a long way to come out of this stigma, to educate the community and to protect our coming generations. Thank you.
Thank you, Dr. Vineetha. It's a very good talk. Both it is a very it is a boon to the postgraduates because they are not very keen on studying pregnancy and syphilis. They want to pass the examination, and this is not a very stock question, but this is very important for the further practice when they go out and start practicing. This is a real problem, and you have given a very good insight into the problem, its challenges, and how to overcome. Very good. Thank you.
Thank you, Dr. Eastwas Pharma is proud to have organized the GLOW academic session for the postgraduates in the dermatology. And Doctor, we are cordially extending our gratitude to Dr. Kottayam sir for organizing and directing the webinar. And our special thanks to Dr. Sandhya George and Dr. Mary Vineetha for sharing their practical experiences on congenital and pregnancy syphilis with our postgraduates. It seems that this will help them for to do better in their exams. Finally, we are thanking for entire faculty team. Thank you so much, Doctor.